Thank you very much, Bruce. We have a few questions from, I presume, remotely, and of course, we have some questions from you guys, I hope. We have roughly 20-25 minutes. For anybody have critical questions or comment, you could stand and just ask any question you want to. Matt, you have some?
So the question from our virtual audience out there. This group represents a lot of people that work in larger centers with large groups of people that are willing to work together. Much of our membership work in small practices that cover multiple community hospitals where there are a lot of turf battles, multidisciplinary turf battles. How do you start a program like this in that sort of environment, and how do you make it work? Open up to the whole group.
Dr. Dapa, you are here as one of the discussants. Do you have any comment to start with? Dr. Dapa is professor of medicine and vascular surgery in my department. Also a guy who, should I call him a traitor? He left cardiology and decided to be part of with Brahman. He thinks the name is more sexy. Yes.
Thank you, Dr. Brahman. It's a great pleasure and honor to be here today, and not only because the chief, Dr. Brahman, is becoming the vascular surgery president, but also to be having the giants in this field, Mark Bates, Dr. Benenati, and Dr. Bruce Gray, to be sitting at the same desk. This just shows how collaboration works. And when I trained at Georgetown with John Laird, I respect him as my mentor and a good teacher who trained me in peripheral intervention. Coming out of the field, I had a big chip on the shoulder, thought I could treat everybody and I was the best, and I was always trying to prove myself. I came to Dr. Brahman and Dr. Bates, and they took me under the wing, and soon I learned that you got to respect the other fields, work together, and how a collaborative work will make you better. I learned a lot of things which I was not trained in the fellowship field, but learned it with humbleness at the cost of a lot of patience, because when you're learning new things, especially coming out of a fellowship, you think you know everything, you're going to bound to make mistakes, and unfortunately it's at the cost of patience. But one great thing I learned from both Brahman and Bates were they were never the people to come out and say, look what I did. They always put their head down and walked away from great cases. And even now I teach the interventional cardiology fellows, learn how to be Bates even for a day, just fake it to be him, because when things are going really bad, this is the guy you want to be having on your right hand to calmly get through the process. Most of the time, make up in your mind, this patient will get through and work it through. And there's a lot of learning to do after 15 years, and I'm humbled that such a great collaboration is what made the success of vascular. And we suggest and also we encourage other people to encourage the same model of using all specialties, cardiology, vascular surgery, and intervention radiology to work together, because each brings different specialties to the field, and also the patient becomes the center of it. And when we let go the ego, the finances, the accolades, and the podium time, the patient care gets the best care.
Anyone from the gym or?
So I think things are very different in small groups versus big groups, and it is easy to sit up here as part of a big group and having figured some of this out, and when you get into where really the majority of practice is in small community hospitals, it is a little bit different. The way I might suggest looking at it is this: is if you have a pie, and the pie isn't going to grow, then there's turf, then there's competition, because everybody wants as much as they can get. But if you could sit down together and look at not what you have, but what you could have, how that pie could grow. So if you're doing DVT work and the surgeons are doing it, and I'll just take my case, but it could be cardiology, and the IRs are doing it, and there's 20 cases to be done, you're going to fight for those 20 cases. But if you recognize that there's really 80 cases that could be done if we work together, then you can start to look at growth. But you have to understand that I think the way to start is to say, what don't we have that we could have? Where's that area of growth? And we know that we're not tapped into the CLI market as well as we could be. We know we're not tapped into the venous market as well as we could be. If we can work together or identify what it is that we don't have. So could two specialties cross cover each other? Well, I can't operate. So if you have, but 90% of your call I can cover, and 90% of my call you can cover. Why can't we spell each other once in a while and provide a little bit? And if you start to look for where the advantages are versus just what we have, then I think you can make some headway. And I just say, since each person here has acknowledged their training through vascular surgery, I just want to say that early in my years, because I know he's here, I should acknowledge that Bruce Perler was a huge role model for me, taught me a lot about collaboration in vascular medicine. So I just wanted to call him out and mention that if I could.
Thank you, Jim. I think Bruce, I see him on the right-hand side all the way there. Yes. Mark, any extra before we go to these questions from the audience?
It's hard to add to the comments that were just made. I think we all recognize that challenge of being able to, in a small, independent, private practice community to build these types of relationships. And the solution there, I think, will be movement away from the fee-for-service model and looking at an outcomes-based model. In the meantime, I think you probably got some good advice here from Jim on how to think about things in a different way.
I see here Cynthia Shortell, Dr. Shortell.
Cynthia Shortell from Duke University. I'm very happy to see this session as part of the Crawford Critical Issues group. It's something that most of you know I'm very passionate about, and I love that we're highlighting it. Later on in the meeting, we're going to be talking about the value of the vascular surgeon, and one of the things that's really important in my institution is convincing our health system that collaboration is important, because a lot of this collaboration takes resources and money. And I'm just wondering if the group could comment on how we can convince the health system that collaboration is valuable for them. I think Dr. Beninati started to discuss a little bit about one strategy that we can use. Thank you.
Thank you, Cynthia. Anybody have any other comment for Dr. Shortell? More than what being said already. Let me remind you, you do not need necessarily to be in the same department to work together. It happened in my model, everybody worked together in the same, and I think one plus in it, we don't compete anymore for money and dollars. However, in your own hospital, particularly in a smaller hospital, as long as you realize if you could convince people around you to be fairly well trained, which I'm hoping with the leadership of the ACC, our leadership, sir, we have a common pathway to understand to do this, as Dr. Bates suggested. It doesn't work by you going over a weekend or the company send you to train on this course and so on. So if all of us did the right thing, then I think you could cross with our coverage, or as Dr. Bate, let us say he might be in the department of cardiology, to be working together. You don't need to be exactly doing the same. For the sake of time, we have another question.
Can I add one thing to this? Just because I think I've been frequently asked by our team at the hospital, how did you get the hospital to dive in with $100 million, and I can't even give them to buy a new CT scanner? And the key to the answer is that there's a misconception that our administrators know what to do. They have no idea. So the key is to build a vision that solves a couple things. It provides pride in the institution. It has a deep seated purpose that everyone that creates a gravitational pull, and that means a lot of thought and a lot of planning on what the business model is going to look like and how you're going to execute on it. So that's I think a really important secret.
Ali, can I just along those specific lines? So I agree, like if you go to the hospital and say, we want to improve quality, and I'm going to work with a cardiologist and a vascular surgeon on one case, and we're going to put all our minds together, that doesn't do anything, because it's more expensive in a way. You're tying up resources. The arguments that we made early on were that if when we sat down at the table, rather than go to the hospital and tell them the complaints or the facility, we came with a solution. And that's what they want to hear. So our solution was, there's a problem with call in our healthcare system. We have different levels of call, different quality. If we merge and you support that and you pay us adequately for call, we'll provide a call solution for you. You'll never hear a complaint. They'll never be looking for someone. You'll never have a problem. And we will unify quality, so you'll never see a surgeon with one set of rules and one set of complications that are acceptable and a radiologist with another. We'll combine the quality. So now we fix quality for them, which was a huge issue with risk management, and we fixed the call issue for them. And so we gave them solutions, and then they turned around and supported that financially. And
That's an excellent point. I could see Jenna, my past fellow. The answer your question, Jenna?
Yes, sir. So, being your fellow was a privilege, and it was exceptionally enjoyable to work with a diffuse, so many different people. And, right now I'm in solo private practice, and it's very different than how I trained. And so how do you propose to institute national and local standards where people are doing inappropriate procedures?
Anyone to take this hot potato?
I think there'll be standards coming down the pike. I know all societies are interested in doing that one way or another. That's coming, whether we like it or not. Secondly, you can only control what you do, and integrity is more important than the dollar. The mantra of follow dollar, follow behavior has to be put to the side. And individual integrity is everything. Character matters, even though it doesn't matter in politics, it matters in practice.
It certainly made a difference when we started seeing cardiologists going to prison because they were doing inappropriate cases, right? And so I think you're starting to see this whole field, or this vantage point of transparency, which is that's the only way that these things are going to change, is when we illuminate, turn the lights on, and actually learn that, why are some interventionalists using atherectomy on 100% of patients? Sure. And why are some doing it on 5% of patients? That kind of thing.
Jenna, as a follow-up also for your question, we're hoping this coming year or so, the leadership of our society with the ACC and perhaps SIR, but the ACC has been more receptive to sit down together and put something as a common pathway. You call it white paper, you call it whatever you want to, not only for privileging, but also for these areas of concern, which is indication and doing so. But it's going to take little time. We'll take the question from my left-hand side.
Thank you. Tom Curry from Providence, Olympia, Washington. One of the huge issues in the room, or in the space, is the perverse disincentives from different organizations. For most compensation models for the employed physicians, flat out, if you're a neurosurgeon, you get paid more per RVU than a vascular surgeon. If you're a cardiologist, you get paid more per RVU than a vascular surgeon. So we're in systems where if a neurosurgeon does a carotid endarterectomy, it's valued more by the company, effectively, than if a vascular surgeon does it. The same thing with an angiogram for a cardiologist versus a vascular surgeon. For TAVR, vascular surgeons aren't even in the room, but many hospitals will clearly point out that if they're involved up front, you're going to have a lower complication risk from access, et cetera. So getting the alignment of appropriate value for the input, especially in terms of safety. When I look at an angiogram on a TAVR patient and say, you can't do this percutaneously, you got to do it cut down. And then when the hospital system says, well, I'm sure the CT surgeon can do that just as well as a vascular surgeon, I'm like, not exactly. We're very lucky in our hospital that we do put the patient first, but it often ends up with, uncompensated care for, TAVR accesses, or uncompensated value for the vascular surgeon. And those, I think, are some pretty huge Uber issues that the large hospital systems, the large multi-specialty employers and CMS are going to eventually need to address. Thank you.
For the sake of time, we have two others. Any major comment related to this? I'm not sure we could solve it, at least with this panel, but I appreciate your point. Who's this guy? Oh, I remember.
Alan Dietzig, Danbury, Connecticut. So this is very informative, and you've all managed to figure out what appears to be the holy grail of working together without ego or finances being in the way. For most of us, however, at least for me, trying to put together or work within a service line is near impossible. I would like to address one aspect of this, finances. You know, everybody comes to this with different incomes. How do you sit down at that table and address that disparity and say we're all going to work together, we're all going to share, when somebody or several of the people in the group are going to be taking a decrease in pay, others may be getting an increase in pay? How do you address that?
Anyone wants, I have an idea, but let me give it to the panelists. Anyone wants to answer that question?
Well, in our institution, we're got a flat salary, no productivity curve, and no RVU basis for that salary to begin with. So that's the way it's been, and it works. Now, some people do 20 cases, some people do 3. I don't really care. If it's, that's just the way it works for us. And I'm not really upset by those that do less or more.
I can echo Dr. Gray's same comments. When I joined, I was doing 100% vascular, maybe a few cardiology, but then as the time evolved, I took more interest in TAVR and started doing more structural, less of vascular. But overall, I think our productivity is okay. But just like Dr. Gray mentioned, if you take out the RVU goal and you go take out the financial incentive behind, but somebody has to keep an eye on the guy who's doing only 20 cases versus somebody who's toiling from morning 6 to evening 6. This can be equated, and we know that all the salaries of my hospital people, at least at the vascular surgery department, is the same. There's no competition, but still egos come in the way. It's not just about finances. Some of them is letting go the number of cases like Dr. Beninati mentioned. So if you look at a broader picture, we have abundance of cases. You just need to not focus on just one patient.
Actually, to echo this, in our system also, the only person who doesn't have the same salary was the preventive medicine vascular specialist, not the one who does intervention, but actually eventually we lost him because he became chairman of medicine in our department. Everybody is equally paid because some of them, like for example, Dr. Dapa, impressive number, he's the one who established the structural heart program, and as part of he's in our department. Still his salary is somewhat similar to everybody else. But I know that doesn't work everywhere, so you just have to find a way where you don't want to also encourage someone to be lazy and do nothing. No, it just has to be, everybody have to put their share, whether in education and teaching, research, plus of course, production, but we don't look to your specific RVU. For the sake of time, we have two other, we have 4 minutes, 3 minutes and a half left. Go ahead, sir.
Hi, Gennady Bulak from Brooklyn. So there was a lot of discussion about collaboration on an institutional level or, between physicians. But I think also one thing to consider is on a patient level, a lot of patients say, I don't want to see a medicine specialist. I want to see my surgeon. I want to see this person. How do you kind of deal with that kind of pushback from the patient? How do you help convince them that these people are also in their best interest and are equally qualified?
I think I would give this to Bruce. Yeah.
Sure. That is actually an important question, and it goes back to the issue of personalized care. That patient is asking for personalized care, and I respect that in the patient. You can offer thoughts and information to your colleagues to complement their care, but I'd respect the the wishes of the patient more than I would any kind of turf issue. And we do that curbside type of information all the time, right? What would you do for this? Would you switch this patient to a NOAC or DOAC, or would you leave them on Coumadin for this? We do that all the time, and sometimes you can do it without having to shuffle the patient around. And I respect the patient's wishes first.
Any other comment from the rest of the panelists? We'll leave the final question to our ex-president, Professor Clem Darling.
More of a comment than anything. Two things is lifestyle has become incredibly important for new hires especially. And so one of the ways we've been able to get around the fiscal part of this is by making lifestyle, much as Dr. Benadonna had talked about covering each other in call and such, is working together has allowed us to have people have more free time with their family. And so I think that's been actually one of the new hires I had was worth $100,000 less salary than they got offered somewhere else. Secondly is the RVUs are the holy grail of hospitals now, but they're truly the Trojan horse, really, that they're trying to, I wouldn't say, well, screw us with. So what we've gone, because they were not meant to be used in a way to reimburse physicians. They were meant to be what cases were valued in certain ways. So we actually negotiated with the hospital to go with group RVUs as opposed to singular RVUs. And as much as Ali had said, then it's the senior the director's purview to look at the RVUs to see if they're appropriate for that person because what they bring to the table. So we batch veins for one person, so they do 8 or 10 veins because they're the vein expert. We have some people who love doing complex open thoracoabdominals, and we have one person that loves doing distals. They all can do 80-90% of it, as much as was said, but it's the group product that's much more important than the personal product, and I think that's one of the things that you can accommodate many of the needs by doing so. And that also then you can bring more of the personal care because you bring the expert in, and that's how, to get back to your question, you can say, well, this person is the expert in this part of our field, and that's why we're using them. So more of a comment, but thank you, and a great topic.
Thank you very much, Clem. I think you probably heard enough. I really appreciate all the people who sat to the end of this discussion. I know with the COVID-19, we didn't expect over 1,000 people to attend. Generally, we have more of you, but trust me, we're very happy to have all of you here. And thank you very much, and I hope you enjoy your 45 minutes luncheon, and we'll see you around 1 o'clock. Thank you.